anesthesia of halothane. What I want to ask the vet students here is, can you update this regimen for me? And I'll have to repeat it to the microphone if you tell me, because we got a couple of problems, including that thiamolol is not really available now for use in dogs, and halothane is not really used. So a couple of quick suggestions on how I should update this for vets of your generation. Isoflurane instead of halothane. Okay, how am I going to induce the anesthesia? Probably use propofol if I was in a clinical setting. And other than that, same acepromazine, atropine, propofol, isoflurane, is that all the drugs, medications we're going to use for our dogs for spay circa 2014? Antibiotics, maybe. Let's stay focused on psychoactive drugs, pain-related drugs. So there's a suggestion to use butorphanol along with the acepromazine. Butorphanol is what category of drugs? Butorphanol is an opioid. And so that's it. Then I finish my spay, I stitch up my dog, I turn off the isoflurane, and away we go. Send her home. Yes? We thought anatomy was the only people having a test today. Is that it? They're just going to turn off the isoflurane and send her home with an NSAID, so a non-steroidal anti-inflammatory drug, another analgesic that's going to send her home. So a little bit difference in drug use for the dogs. So when I was a student, 1985, we did not use intraoperative analgesics, so the dogs were not getting butorphanol as a pre-medication, and we were not using post-op analgesia. They were not getting opioids, they were not getting NSAIDs, they were not getting lidocaine or bupivacaine. That was the standard of care in clinical practice, where the real issue is, how am I doing for this animal as a patient? And that was the standard of care for dogs in the research setting, where they're both patients and subjects or models. So the legal standard of care for the dogs in those days was that there was really no legal, then as now, standard of care. There's no legal requirement to use perioperative or perisurgical analgesics for the dogs, whether they were in teaching labs or in private practice, though even then you could read the laws to say, you know what, here in research world and teaching world, you really do need to be thinking about more than just are they anesthetized for surgery, but also are they getting pain medications to deal with the after effects of the surgery. And when I graduated from veterinary college, I got friends of mine who were in private practice to understand that we in the research world, if we were doing these surgeries, would use analgesics in the private practice world. So in one sense, we in research were actually leading pain management and awareness of pain management back in the 20th century. Back in those days, this was just before the institution requirement that campuses like Tufts have an institutional animal care and use committee. So the person who decided what pain management to use for these dogs in this laboratory were the professors who were teaching the laboratory. They did not have to get special approval to use dogs, and they did not have to have an animal care use committee look at their plans for pain management when we amateur surgeons were doing these major surgeries on these dogs. But even then, because it started around 1971, the institution where I worked, where I learned, later became a staff veterinarian, we were required to report every year to the Department of Agriculture how many animals we used in procedures, teaching or research procedures that may have had more than minor or momentary pain or distress, for which the pain medications were withheld because we would be worried about what might happen to the data if we use pain medications. Now I know, because I was also a student member on our Animal Care Use Committee, that when we reported these dogs to the USDA, we reported them as animals who did get full anesthesia. We did not put them in the special reporting category for dogs that did not get full anesthesia. So we had a different standard of reporting to the USDA on our use and our use of painkillers and attention to pain in the animals. So before I want to go on to talk about some of what has changed, what I want to do is have us all on the same page with some definitions. And some of these things may seem fairly obvious to you, but they're things I think about as being in need of some definition. Pain and painful procedures. What's an animal, especially what's an animal about whom we should be concerned when we talk about pain and pain management? I'm going to talk a bit as we go on about Category E experiments or protocols, so we should know what those are. And I'm going to talk about what do I mean by talking about progress. So first definition, does this show up? Yeah. Pain, as defined by the International Association for the Study of Pain, is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. And they go on to say, you don't need to be able to talk. You don't need to be able to describe the experience to have people assess you and decide you're in pain, whether you're a little neonatal infant, human being, or whether you're a nonverbal animal. But the important thing to focus on is that pain is not just the nociception, not just the wiring, not just the mechanics of touching a hot plate and a message going up to your brain. That's nociception. Pain is what your brain does with that, processes that experience, not just as something it recognizes, I should pull my hand away, but something it recognizes as truly, emotionally unpleasant. Pull my hand away, avoid going through that situation in the future because it's not something I want to experience. From the Animal Welfare Act, we don't have a definition so much of pain, but of a painful procedure. And here, this is something we discussed in the group yesterday. There's sort of a legal requirement to do what some people would refer to as anthropomorphism, which is to think about the human experience and try to apply what we know about people to animals. So a painful procedure is a procedure that would reasonably be expected to cause more than slight or momentary pain or distress in a human being to which that procedure was applied. But they also, in the laws under which we operate, set a threshold. So pain in excess of that caused by injection or other minor procedures. So when we talk about deliberating IACUC meetings about painful procedures, we're not really worried about the kind of pain that giving a dog a vaccine might cause. We're worried about more severe pain and pain that lasts longer than the time it takes to give a quick subcutaneous injection of a mostly non-irritating substance. So that's one set of definitions, pain and painful procedure. But what's an animal? Here again, we have a legal definition, those of us who work in research and teaching, that an animal in the Animal Welfare Act has so many exclusions that essentially, to the extent that I can tell, roughly 0% of the animals in laboratories are covered by the Animal Welfare Act. To a close approximation, probably closer to 0 than to 1% of the animals in laboratories are covered by this law because this law excludes fish, frogs, birds, invertebrates, as well as mice and rats that are bred for research. So because we don't keep formal records and are required to report on all those excluded animals, it's hard to know for absolutely certain how many animals are excluded. But my best projection is that mice are at least 97% of the mammals that are used in laboratories. then add in the fish, the frogs, the others, and you get down to a law that essentially does not cover any animals. It's a very powerful law in its way, but mostly the animals a USDA inspector will look for are a tiny little sliver, and the rest of the animals are completely invisible to our government inspectors. But most of us operate under another set of guidelines that require us to pay attention to a book called the Guide for the Care and Use of Laboratory Animals, which is what the NIH uses as animal welfare standards for projects that the NIH is funding, or the Public Health Service is funding. And they extend their coverage more broadly, including a statement in the most recent update of their guidelines that the ability to experience and respond to pain is widespread in the animal kingdom and extends beyond vertebrates. So when we think about pain in laboratory animals, we think both about what are our legal commitments to the sliver of animals covered by the Animal Welfare Act, to the bigger set of animals, all vertebrate animals covered by Public Health Service rules, to animals beyond the vertebrates that do not, in this country, have legal protections necessarily. But when we start thinking about our ethical commitments, we have to start thinking, do we expand beyond just mammals? Do we expand beyond just vertebrates? Do we have good biological reason to think that hermit crabs, amoeba, roundworms, other non-mammals, animals very foreign to us, should be part of this fold or not? And do we draw a sharp line, or do we draw sort of a fuzzy line that we're more concerned? We think mammals are more capable of experiencing pain and distress than amoebas are. Anytime we really try to fine-tune what we're doing, we need to stop and say, wait a second, animal is even itself a word in need of definition. I mentioned category E. So is this a thing that's familiar to you, a term that most of you are familiar with, what category E means? I can't see you raising your hands out in radio land, but so let me just review for you that when we report, so this comes from the form the USDA has us use to report our animal use, so that's liver of animals. Let me ask, at Tufts, do you also use the same CDE system for your non-USDA animals? Yeah, so most institutions that I know of use this USDA system for their non-USDA species as well, for their mice and rats. And so column E is the one I'm most concerned about. Column E is when we say we know we're going to do things that cause pain or distress to our animals. Maybe intentionally we're going to cause pain and distress because we're studying pain, or maybe unintentionally because we're studying cancer biology and advanced cancers are painful. We're studying inflammation, and inflammation can be painful. If we could magically wish the pain away, we would, but we can't do it with magic. We have to get beyond the magical thing. So we very carefully think about studies that could cause pain or distress to the animals, and where the researcher says, I have serious concerns that if I use medications to treat that pain, I am going to seriously interfere with the study that I'm doing. So those are the studies that are category. There's both a threshold question, is it more pain than a simple vaccine? And there's a, are you treating that pain or are you not? And if you're not, are you not treating it because of your concern for what it will do to the data? Sometimes we don't treat pain because we're afraid the painkillers will impact animal health in a negative way. The last thing to talk about is how would we recognize progress if we were having it? Are we looking to reduce the number of category E animals? Are we somehow trying to figure out how to assess how complete the pain management that we are doing for those animals where we are trying to do complete pain management? Or are we judging progress by how well we review the justifications for category E and for non-category E pain? So it's not entirely clear to me exactly what we're going to do to measure progress. But I think we have at least some sense of what that would look like. So progress, 1985 versus 2014. Now perioperative analgesia is the widespread standard of care. So if you do an abdominal surgery to remove the ovaries and uterus of a dog and expect her to wake up from that, you're probably going to use up to 3 or more categories of analgesics. You're going to use a local anesthetic like lidocaine. You're going to use a non-steroidal anti-inflammatories like carprofen or meloxicam. You're going to use the opioids like butorphanol or buprenorphine. That's now the standard of care. Now we have a difference since 1986 in the birth of IACUCs that a researcher or a teacher does not work in isolation making decisions about pain management for her animals. It's part of a community activity that an animal health use committee gets involved. There's special stipulations that veterinarians are consulted to advise on pain management. Even on a veterinary campus where most of your investigators may be veterinarians themselves, the official veterinarian, the attending veterinarian of the university, has to have some sort of voice. He or his designate on what do I think the best approach for pain management is going to be for these animals. So it's more of a community activity now with mandated veterinarian involvement. We've changed the threshold of category E. So last time I talked about this in an audience, I got a show of hands that showed some real variety that if people in 2014 managed pain for dog spay the way we did as a student in 1985, would they now report that as category E? And it's really because these things are decided largely institution by institution, unless the USDA comes calling and says, I have a difference of opinion. Different IACUCs make their own decisions about how to report things. I know on my campus, if we allow a research surgery to happen and the animals do not get analgesics after the anesthetic is turned off, we list those as category E. We say it's very nice that you anesthetize the animal for the surgery, but this animal woke up. And now there's all this potential for significant pain, and you aren't treating it, so we're going to put these animals in category E. And I don't want to split hairs on how to define and report these things, because then we get into the discussions of, well, if you vets like to have 3 classes of analgesics, but all I'm going to use is the local, or all I'm going to use is the NSAID, is that a category E or is that a category E? And it's not worth for the purposes of our talk today to get really bogged down in splitting hairs on which category to put things in. Probably one of the biggest types of progress we've made is that I do believe we are now both better at seeing pain in animals, and we're much, much, much better off with a much better selection of drugs that are available. Because I've looked at a lot of the history of how this profession has developed. Be sure to read my book. You can get it for about $3 on Amazon. In the past, veterinarians and scientists would say, well, we completely treat the pain in the animals, and you don't really need to worry about what we're doing to the animals. But at the time, we didn't have buprenorphine or butorphanol that might give 4, 6, or 8, or 12 hours of analgesia. We had drugs like morphine and pentazocine that might give 40 minutes of analgesia. So we might have been using the best available drugs, but the best available drugs, whether for people or for animals, were really lacking. The NSAIDs, there was aspirin. Aspirin's good, but it's not as good as something like meloxicam or carprofen, especially if you want to go home at 5, 6 o'clock in the evening and leave your animal unattended and untreated until the morning. Aspirin is not going to last that long. So big sign of progress, or big factor of progress, is that we have better tools available for these animals. And so with that, does that mean that maybe animal pain is actually a problem we've conquered and solved and can move on? And there are folks who say, yeah, pain is not really a problem we need to be working on. that really we need to turn our attention to the stress. All the animals we use in research, they're all confined, they're all manipulated, they're all at risk of distress. And only a subset of those animals are really at risk of pain. So maybe it's time to turn our attention away from pain and focus on distress. Others say, well, yes, pain is no longer a problem for animals because now we have new laws that say that you have to have a veterinarian involved in prescribing or advising the ethical scientists on what kind of pain management to use for their animals. So we have vets. How could we possibly have a problem with animal pain? So my concern is to both of these things that, yeah, we need to think about animal distress, but that doesn't mean we've solved animal pain. And two, it's very nice that veterinarians have more of a voice in how to manage pain for animals, but veterinarians' voice is no better than the available tools for diagnosing pain, for recognizing pain, treating pain, and for making those decisions about when it's justified to do Category E studies and not treat the pain at all. So very nice being a veterinarian, but veterinarians can't go beyond the available tools. We can't successfully treat antibiotic-resistant bugs if we don't have an antibiotic that works. And we can't successfully treat some kinds of pain if we don't have the right tools and drugs available to us. So, a couple of things I want to talk to you about. Can we improve our pain treatment options? So can we get some technical improvements going on? Looking out here at all these great young veterinary students who are going to be the next wave of figuring out better pain management strategies and tools for our animals. Do we need to rethink how we look at Category E studies? And can we improve our shared knowledge base on both of these sets of issues? So, no time to go into all the different ways of measuring pain in animals. Some of them are looking for special pain behaviors like back arches and squinty little faces and grimaces. Some of them are looking for decreases in normal behaviors like wheel running or food consumption or nest building. We have down here in the corner, you can see my little mouse licking his foot, a very formal test for measuring pain in animals in which we put them on a hot plate and measure how long it takes them to say essentially how that hurts, lick my foot, take the animal off of that hot plate so that he doesn't stay there and potentially suffer or have tissue damage, or even a more advanced approach to trying to study pain and how much it means to the animal by giving them a choice of two chambers, teaching them in this chamber, we treat your pain with a painkiller. In this chamber, we treat your pain with a placebo, and we give you access now to both chambers and ask you, does the pain matter enough to you? Does the painkiller work well enough for you that you're going to go and choose the chamber you're in? So we've got lots of different tools for trying to study pain. And the big challenge we have, both for using animals as models to learn more about pain in people, but also doing the clinical research to try to figure out what are the best pain killers for our animals and how severely painful is a particular procedure or manipulation to an animal, is that if we're not using standardized testing, and the literature right now is not standardized, we're probably still really out there in the weeds trying to figure out how do I compare apples against oranges if the apples I'm weighing on a gram scale and the oranges I'm weighing measuring by counting. So I have some pain measures that are very sensitive and will pick up subtle pain. I have some pain measures that could hit you over the head because they're so obvious if the pain is really severe. And what we don't have very well right now is a really good standardized set of tests that we use when we try to develop better pain measures. So this one, for instance, is hot plate test, highly standardized, reproducible test, but unfortunately, it's mostly meaningless for clinical pain because most of the pain we worry about with animals isn't what's the pain of standing on something that's really hot. It's what's the pain that's associated with things like surgery or other injuries, arthritis and other inflammatory processes with cancer. Those kinds of pain are not well modeled on a hot plate. Plus, the kinds of painkillers that might work well for them, that help manage the inflammation as well as actually treating the pain, are not well measured on a hot plate. So it's really nice to compare different opioids on a hot plate. It gives you some relative sense of their potency. But beyond that, it's a test that's not very useful. And yet when we look to what's the best dose of this drug to use in mice, sometimes hot plate data are the best thing that's out there in the literature. So it's nice to be a veterinarian and be empowered to be able to say, I have a voice in what pain management you use for your animals, but I just don't know what would be best, because the best I have is some hot plate data. It's mostly irrelevant to things like surgical pain. So we need to standardize that and get better. We need to, as we standardize the measures we use, also standardize what are we going to look at, for instance, in terms of animal strains, because we find that there's a real strong genetic difference. So what this slide is trying to show you is for a particular two different sets of pain measures, thermal hypersensitivity, so how much mice react to a hot plate, and mechanical, how much they react to being poked, that they will differ. Different animal strains, mouse strains here. So up top we have the thermal sensitivity, down here we have mechanical sensitivity, and the same strain, little C57 black 6 mice, one of the most common strains, react very differently to mechanical versus thermal, whereas other mice show a different profile. And when I go to say, okay, you're going to do this experiment and you're going to work with some DBA2 mice, well, the only available analgesia data I have actually come from C57 mice, and they're different animals. They have a different pain profile, and they have a different analgesia responsiveness profile. And we look at some of these different strains, which is what's along the bottom here, and their reactivity, their responsiveness to either aspirin or acetaminophen, but you could do the same sort of studies with every other analgesic we have. And we start seeing things like, look at this. For all how sensitive this strain way over here might be to these drugs, Val C, maybe the second most common strain of mice we work with, not very responsive to these drugs. And yet, this is the information we have available. So we need better drugs, better ways of measuring that the drugs are working, and it needs to be strain-specific, species-specific information. Let me move on. I tend to pack more into a slideshow than I can get from the available time. But we have concerns. Big concern I really want to touch at least briefly on is, when do we withhold medications? We as practicing veterinarians know sometimes we'll withhold medications because we think for this animal, these medications could be quite dangerous. You're in kidney failure, maybe I don't want to use NSAIDs for you. You've had head trauma, maybe I don't want to use opioids for you. I know the side effects of those for your health and welfare could be bad, and so I may leave some of that pain untreated for my animals as patients. But animals in the laboratories are not just patients, they're also models, and so I very much worry how much could use of drugs interfere with an experiment that's trying to be done. Those are the category E animals. Roughly current data, actually these come from 2007, but it seems to be continuing now, is that somewhere in the neighborhood of 8%, 7% of the animals reported to the USDA are in category E, significant pain, not treated because of concerns of what pain treatments will do to an experiment. My guess is the percentages could be higher with rats and mice because they're the ones who are used on all the studies of arthritis and the cancer studies and the studies where we really expect to see a lot of pain occurring. So probably I would guess at least that 8%. But even if it's the same, that's still a lot of animals that we're concerned about in this category E. So to oversimplify, this is high school biology. I want to set up an experiment with animals. The most simplistic version of that is I have two groups. I have my experimental, I have my control animals. They should be identical in all ways except for whatever the manipulation is I'm trying to study. What's the effect of this gene? Well, I have all my animals have that gene, and the others have that gene knocked out. Or what's the difference? What's the effect of this drug? My experimental animals get the drug, my controls get a placebo. All the manipulations are the same, and my hope is that leads me to statistically significant differences between those two groups that I can attribute to the manipulation I did. And what I need to do in the process is to control for all the different little variables that could do it. Do I have the same person measuring the outcome of the animals? Are they all eating the same? Are they the same genetic makeup? Are they all living in the same group size? Am I studying only the dominant animals in the group and the subordinate animals in the group? Am I trying to ignore the effect of social hierarchy? But for our purposes, the important thing we want to control for is drugs used, but also the pain of the procedure and the things related to our manipulations like inflammation, but also all the other side effects of pain. Animal in pain may not want to eat. Animal in pain may not move as much. Animal in pain may give you different outputs than an animal not in pain. So we're trying to, as scientists, be as careful as we can, making sure that we're controlling for all of these things. And the simple thing is to say, don't use the drugs. Get rid of those analgesics. I know they have effects throughout the body without necessarily taking the next step of thinking, well, what are the potential effects of untreated pain on this animal as a model? And the karmic theory of pain and painkillers is that everything we do to an animal has effects throughout the body and throughout time. If we cause pain, if we cause tissue damage, if we cause inflammation, if we treat those things with drugs, all of those things are going to affect how this animal develops through time. There's no such thing as the pure animal completely free of these potential artifacts. And yet, it's so easy for us to go to the place of saying, get rid of the drugs and everything will be fine. I won't even try to explain the whole slide. This is one set of studies that found that if I do surgery at the time that I'm injecting cells to study their ability to metastasize to the lungs, whether I treat that surgery or not affects my metastatic rate. And what you find, if you look closely at the data, are that compared to a completely otherwise unmanipulated animal who just gets the tumor cells, surgery will affect the metastatic rate. Untreated pain and injury and inflammation of surgery will be an experimental artifact. It will affect your data. And different choices, 3 different choices of opioid analgesics may either counter the effect of surgery, exacerbate the effect of surgery, but the take-home message really is that untreated surgery can be an unwanted research variable. Use of pain medications can be an unwanted research variable, and the choice, the particular pain medication you choose is going to be. So we're really in kind of a pickle because the more we look at this, the more we see that pain does have effects throughout the body. It's going to complicate interpretation of research data. Painkillers do. It's really not as simple as just saying, I'm going to do surgery, I'll get 2 days of painkillers, and then we reset everything to 0 and the animal will go on to be an experimental subject. All of that you did at the time of the surgery is going to be carried through. The way I approach this, I do a birth to death inventory. I start with the potential pain of being genotyped. I go to the potential pain of how I euthanize the animal. I assess all the different points where there could be pain. Then I add up all the potential pain, all the potential distress, take away what I've managed by using refinements, and those refinements could include analgesics. And what I'm left with is the residual pain and distress that I can then have my eye conversation about, is this justifiable or is this not? But starting with really close, careful assessment of how much pain there's going to be is the first step. And really, all of that is about treating the acute and subacute pain of surgery. What we really have to worry about with our laboratory animals is chronic pain, because the surgical pain mostly, for most of the animals, will pass with time, whether you've treated it during the acute phase or not. The reason scientists for years may have used less painkillers than veterinarians want is that we know from experience the animals do survive this. It may hurt for a few days. That may affect their use of subjects in ways we may or may not realize, but they survive. They go on. But the pain of surgery, it passes. But we also have very serious concerns about chronic pain with our laboratory animals. They get old. They get arthritis. They go on to cancer studies. They have cancers. Some cancers are quite painful. They are inflammatory disease or infectious disease studies. There's all these potential sources of ongoing significant pain. And it's a problem in people. We don't have good tools in people yet for completely managing chronic pain. That's why we use animals in pain research, not for surgical pain. We use animals in pain research. There's so much progress still needed for control of human pain, chronic stuff. And so what we do instead with animals in chronic conditions is we really very carefully focus on what's the experiment, when's the earliest you get the data you need, and can you then remove the animal from study, which for laboratory animals usually means euthanizing that animal. If I'm interested in metastatic cancer and I have an assay for finding out early stages of metastatic rates, then I should euthanize the animal there before that starts making them sick and painful. If I'm interested in pain management or even in treatment of advanced metastatic disease, I have to have different endpoints, and the animals in those studies may suffer. But definitely, I need to be very clear, what's the experimental question I'm asking so I can try to set these endpoints. I guess the last thing I want to say, and my scientists have moved on to other venues, but it's try to make a pitch for a fourth R. So we know the 3 R's of reduce, refine, replace, and lots of people like to talk about, well, there's also a fourth R, this or this or this or this. For me, the fourth R is writing. If we're not writing in our scientific reports our experiments on animals and what pain management we did for those animals, we're really doing those animals a disservice. So here's a project I have a student working on. What I want you to look at is the green, not the teal, and it's what I call the publication gap. We're looking at a bunch of different experimental models that require anesthesia. Whether you care about the animals or not, you cannot do brain surgery on a mouse if that mouse is awake and jumping around. The animal needs to be anesthetized. So when I look at research reports, we study tumors in the brains of mice after we injected them into the brain. Well, I know they needed anesthesia to hold the mouse still, but I look at their reports and they don't mention the anesthesia. And so if they're not mentioning anesthesia, I worry that they're not mentioning analgesia, and then I worry that somebody else comes along to replicate that work and says, well, I want to do a similar study, but I can't use analgesics because I've looked at the literature. People aren't using analgesics. Well, it's not that they're not using analgesics. It's that we don't have the mindset to think, this is a really important experimental variable we need to report on, but we haven't gotten ourselves to the place where we're reporting on that. So we look at the literature and assume if people aren't saying they use buprenorphine and NSAIDs for their mouse surgery, that means they're not using it. But that may not be true at all. So we really need to push the new standards that have been put out. Some journals are buying into them, that you need to really report more detail in your animal experiments so that we can assess the quality of the science and that we can actually replicate it. And I think that's all I have to say to you about pain management. So we have some questions. Yeah, there's time for questions if people have to disappear. So you're the tuition payers, stay as long as you're getting your tuition dollars. Or yeah, sir. Yeah. So the question is, what are the standard ways of measuring pain? I'm sad to say that to a great extent, the state of the art right now is people still figuring out what they think is the best measure. So Alicia Karras here is trying to do that, sort of looking at will animals find nest material and incorporate it as an example of something that we can fairly quickly cage side measure for the animals. Some of the big gurus in pain assessment in animals, folks in Montreal, in Jeff Mogul's lab, like to look at things like pain faces, grimacing, as a measure of pain. And for the same pain insult, they will find evidence of pain lasting longer in their animals than what Paul Flecknell in England finds when he's measuring the amount of spontaneous behavior, how much activity they have. So we don't have a standardized method. So if you're looking at activity levels, those may return to normal faster than loss of pain faces or return to full nest building behavior. So we're not standardized either for using animals as models for people or for using animals in clinical development of pain strategies for the animals. Yes, okay. Uh-huh. So the question is, what are some of the tools we use in laboratory animals that might apply to clinical practice with dogs and livestock? And really, the tools are essentially the same. We look at behavioral stuff, in particular, response to a particular thing. We think this could be painful. We think it would be painful to us. Being dehorned, we don't know. We don't have horn bugs. But we think, well, there's skin incisions being made or cutting through skin. We measure behavior, and we try to look for very pain-specific behaviors. And often, unfortunately, the really best clinical research of pain management for animals often requires having an untreated control group. But if you do that and you look at comparing methods of castration for lambs, well, you look at things and see that, well, look at this. The little lambs that we castrated with this technique, it did not give them painkillers. We spent a lot of time turning around looking at their scrotum. They know something's wrong, and they do more of that than the guys that got painkillers. We look at steroid levels, so cortisol in calf blood or saliva or feces, and we see, oh, look at that. We have a cortisol peak that seems to be related to the acute pain, and then an ongoing cortisol peak that seems to be related to the residual pain. And we can get rid of that first one or damp it down with opioids or with lidocaine. And we can kind of get rid of that second elevation if we're using a non-steroidal anti-inflammatory. So we're using a physiological measure and comparing response to analgesic versus non-analgesic. So a lot of those same tools coming out from laboratories to those species, as well as all the clinical stuff you know, both watching normal spontaneous behavior, looking at things like weight, loss of body condition, disease rates in a flock, and then doing what vets do so well, which is say, oh, you had an incision here on your chest, let me poke it, see if it still hurts, or you're kind of lame on that foot, let me crank on that foot tester. So can I elicit pain? Can I make you run around me in a circle and see if I can elicit pain that's obvious of walking, that's not. So all the same general tools. And do we have questions from our studio audience? No? Okay, great. You're going to do something about this. So there's so much to be done, and really, you know, there's so little funding for the research on animal pain for animal sake. More funding for animals as models. And really, we need good, careful, thorough work, not just every now and then somebody like me finds a little time, grabs 8 mice of one strain and does some study to try to get some new piece of information. But really, good, careful studies that say, let's take 3 common but different inbred strains of mice. Let's do a nice battery of tests. Let's really do really high-quality research with enough animals to see a significant difference. Do a clinically relevant test and really get that database. Yeah, David. Okay, so the question is, where I work, do we try to give painkillers prescriptively, or do we have scientists just write, I will give painkillers if I see evidence of pain, right, on an as-needed basis? And there are a couple of reasons I push for the prescriptive or preventive use of pain. One is, I know surgery is painful, so I really want every animal to wake up from anesthesia with a painkiller already on board at blood levels that should be therapeutic. So I really want them coming out of the gate with some pain management. Then I think about the fact that we're going to go home at 5 or 6 in the evening, and we're not going to be there to assess those animals until 6 in the morning. People will come in for monkeys and check them at midnight. People won't come in at midnight for mice and check them for signs of pain. So pain is so hard to see, and we're not going to be there looking for it. I want to err on the side of treatment if I possibly can. And finally, I do think there's a scientific value in saying, why don't we treat all the animals with the painkillers and not just go into data analysis saying, okay, so wait a second, let's try to sort out. These 6 we gave painkillers to, these 13 we did not. Let's try to do the statistics and see if those fall into a different group. So I think it's sounder science also to try to treat all of the animals uniformly. So for lots of reasons, I do really push for at least 24 to 36 hours to treat the animals. And I think crowds are gathering and coming and put better use to this room. So thanks very much for your attention. Thank you. Okay.